Wow, it's time for a Puscast covering the last 2 weeks of February 2015. I thought with a short month, this would be a quick podcast, but I have a ton of articles I wandered across. So we'll see how quickly and how many we can go through. I'm still shooting, as always, for half an hour. Let's move on, though, straight to the literature, shall we? A couple years ago, I gave a short talk to a group of surgeons and anesthesiologists about hand hygiene. And I always comment about where people put their hands. Well, as I gave the talk, I sort of mentally kept track of how many people put their hands where, and at least half of the people stuck their hands in their mouth or other places during the talk. This has been validated now in the medical literature. There's a study that looked at how often people in the medical environment touch their faces, and the answer is all the time. 44% of the time they touch mucous membranes. 56% of the time they touch their face. It is very common for your hands to wander when you're not paying attention. It's why you need to do hand hygiene even when you don't think you need to, because your hands went all sorts of disgusting places. You just don't realize it. So many infections out there. You probably heard of the Bourbon virus. This was a patient in Bourbon County in the Midwest who developed fever, thrombocytopenia, multi-organ system failure, and subsequently died. They have isolated the DNA, and it looks to be in the genus of thogotovirus, Thogotovirus. It's in the family closely related to viruses found in the East, the Dori, Dhori, and Batkin, Batken viruses. So in the U.S., we have the Bourbon virus. In the East, they have the Dori and Batkin viruses. This is one of several viruses now in the United States that have risen their ugly heads, including the Heartland virus and the fever with thrombocytopenia viruses. There are a lot of tick-borne illnesses out there we have yet to identify or are just starting to identify. My only hope is that Donald Trump does not learn about the Bourbon virus, because he will probably propose that nobody from Kansas be allowed in the United States. And please, whenever you have a novel virus, those of you who write these up, give us pronunciation guides so I know how to pronounce thogotovirus. It was a crappy flu year on two fronts. The first was that we had a lot of flu, and I'm glad it's on the way out. And the second, that the vaccine really did stink on ice this year. The current data suggests that it is a whopping 18% effective in preventing influenza, mostly due to the H3N2 drift that's occurred, so that the vaccine no longer covers the circulating strain. Interestingly, the study also reports that it was extremely effective against bee influenza, 95%. But B only accounts for a distinct minority of circulating flu strains. It's still A influenza, and this year's been the H3, and the vaccine, unfortunately, just ain't that good. Occasionally, people get allergic reactions after receiving the flu vaccine, hypersensitivity type reactions with shortness of breath and wheezing, and it's attributed to the egg component of the vaccine, since the majority of influenza are grown in eggs, chicken eggs to be exact. The study, though, looked at the reports on the vaccine adverse event reporting system of allergic reactions in patients who received the recombinant vaccine, which of course would not have any egg components in it. And they did find a smattering of cases of people who had allergic reactions following receipt of the recombinant vaccine. There are, of course, all sorts of issues with the VAERS system, but nonetheless, the conclusion would be that it's not necessarily the egg component in the vaccine that leads to allergic reactions. And finally, another meta-analysis on the efficacy of steroids in patients with severe influenza. They could find no evidence that it works, although, as is always the case with a meta-analysis, it's garbage in, garbage out, and the studies were not optimal to come to a conclusion. So, as always, further research is required. So, like the pneumococcal vaccine, they're ratcheting up the number of viruses in the HPV vaccine. The quadrivalent has 6, 11, 16, and 18. Now they've added 5 more, 31, 33, 45, 52, 58. Those would make great Powerball numbers. You win your Powerball using HPV vaccine strains. That'd be kind of cool. Anyway, the 9-valent vaccine has better efficacy than the quadrivalent vaccine, decreasing, quote, high-grade cervical, vulvar, and vaginal disease related to those new strains down to 0.1 per thousand patient years versus 1.6 in the quadrivalent group. They had a nice immune response, but a little more adverse reactions at the site. I would suppose more antigens equals more reaction. So I assume in the near future we'll now offer the 9-valent HPV vaccine rather than the quadrivalent. So 2, quote, real-world, unquote, studies show that pre-exposure prophylaxis is indeed effective in preventing the spread of HIV. It looks to be about 86% effective. In both trials, patients received tenofovir and emtricitabine as their prophylactic, i.e. Truvada, which is pretty good. One was called the PROUD study, which is not bad. The other is the IPERGAY. So while about 85% effectiveness is excellent, on the other hand, you can think of it as 15% of the time they failed, which is dreadful. There was no difference in either group in other sexually transmitted diseases, suggesting that indeed they were well randomized and that both groups were having high-risk behaviors. The 8 billion people now on the planet suggests that condoms are not used as often as they should be for birth control, much less for the prevention of STDs. So it's nice to know that we have another alternative way of preventing the spread of HIV. A meta-analysis on the use of topical steroids in cold sores. They looked at 4 different studies and found that people that had topical steroids, in addition to an antiviral for their cold sores, healed faster, had less pain, and curiously had fewer recurrences. I don't understand how they could have fewer recurrences. And the p-values were good, 0.001, 0.007 kind of deal. So it would appear that for cold sores, adding steroids benefits the patient symptomatically, though I would sure love a mechanism by which topical steroids would decrease the recurrence rate. One would think it wouldn't make any difference either way. I get asked all the time in clinic whether or not stress increases your risk for an infection. And stress does have a lot of downsides, but it's always hard to say that a specific stress or stressors led to a specific infection or other medical problem. This study asked the question, does stress cause herpes zoster to flare? And at least by their criteria, the answer would be no. The stressor they looked at in the case control trial was death of a spouse or a catastrophic medical illness, and found that zoster did not increase after those particular stressors. And it was in a large population, almost 40,000 people. So does stress cause your zoster to flare? Not according to this study. Who knows? Maybe in a significant number of people, the death of a spouse was a time for celebration. Not everybody has happy marriages, although it's still stressful by a different criteria. I tend to be a bit skeptical about the whole mind-body thing, and I find talking about it stressful. Hey, what's this lesion on my lip? Is this the new nomenclature or nomenclature? People who inject drugs, PWID? PWIDs get hepatitis C. How to prevent it? And for you injection drug users out there, you can probably best disinfect your shared needles with bleach. And bleach is more effective in this study than other household cleaning agents. and use the bleach at a 1 to 10 dilution, remembering, of course, to use some water to clean out the residual bleach. I need to make sure that my injection drug using listeners keep their syringes and needles nice and clean and free of hepatitis C. See, this is a public service podcast. Here's a cool bit of epidemiologic history. Murine typhus, due to Rickettsia typhi, increased in the South in the late 40s. Why? Well, they switched from cotton to peanuts, and as a result of food supply, i.e. peanuts, the rat population multiplied, and there was a big outbreak of murine typhus in the South. There's now an ongoing increase in Galveston, which is in Texas. They're not certain exactly why. They wonder if it's rat-related, or like in the Los Angeles area, it is due to possums. They're still looking into the exact epidemiologic shift as of this article, but it looks like Rickettsia typhi is now in Galveston, perhaps in rats, perhaps in possums, perhaps in cats. I kind of sound like Dr. Seuss there, don't I? How much C. difficile is spread in the hospital as opposed to reactivating or being acquired in the hospital from, say, food sources is as of yet to be determined, although much of the C. diff that's acquired in the hospital doesn't come from the hospital. This was an interesting study, which probably would apply if you're having a problem with an outbreak in your hospital, where they treated everybody with fidaxomicin. And they found that there was less C. difficile in the environment, which did not occur in patients on vancomycin or metronidazole. So it would suggest that A, if all your patients are independently wealthy, because fidaxomicin costs about as much as a fully loaded MacBook Air, and you're having outbreaks where you're worried about environmental spread, this would suggest that fidaxomicin may be of benefit. Or perhaps, people could wash their damn hands. I obviously live in a fantasy world. A while back, there was a big outbreak of listeriosis associated with cantaloupes. The question then would be pregnant women. How much risk are they? Since pregnancy is one of the conditions where you can get severe listeriosis, and the fear is that it then infects the fetus, causing death or premature delivery. So they did some calculations in Colorado trying to figure out, well, how many people who were pregnant could have eaten these contaminated cantaloupes. And they guesstimated that between 6,500 and 12,000 pregnant women could have eaten contaminated cantaloupes during the time. And they came up with an attack rate based upon data of a risk of about 1 per 10,000 exposed pregnant women. So it is a risk, but 1 in 10,000 is a fairly small risk. As a comparator, 5% of the deaths of H1N1 were in pregnant women in 2009. So your bigger risk is probably H1N1, not cantaloupes. Still, I'd get the vaccine and deep fry my cantaloupe. Everything should be deep fried. But then my theory has always been physicians will die of their specialty, so I am destined to die of an infectious disease, not cardiovascular disease. There is, of course, zero data to support that contention, but it does make me glad I'm not a gynecologist. I remember that poem from, I think, Lord of the Rings. All that glitters is not gold. All who wander are not lost. All with exudative tonsillitis may not have group A strep. Now, this study was in the Annals, and they'd published some other articles on this about a decade or more ago now. But they looked at the incidence of certain organisms in patients with symptomatic pharyngitis. It was those in the 15 to 30 age group who were presenting to a student health clinic. And they looked with PCR looking for 4 different bacteria. And they found the most common etiology of a sore throat in this population was Fusobacterium necrophorum. 20% had that. Half again as many, 10% had group A strep, and there's a smattering of group C strep, 9%, and mycoplasma, 2%. But if you have someone who comes in with an acute pharyngitis, swollen lymph nodes, fevers, tonsillar exudate, no cough, and their rapid strep is negative, that doesn't mean they wouldn't necessarily benefit from penicillin, because they could have group C/G strep, or more importantly and more commonly in that age group, Fusobacterium. And the problem with Fusobacterium is it goes on to cause peritonsillar abscesses and Lemierre syndrome, septic thrombophlebitis of the internal jugular. This finding of the common etiology of sore throat in that age group being Fusobacterium is not limited to one study and should be factored into whether or not you give antibiotics in the outpatient setting in someone who has an acute pharyngitis. I haven't treated a case of acute pharyngitis in, 30 years? My kids never got tonsillitis and only one case of otitis, so I haven't had much to do with outpatient young people with acute illnesses. But damn it, I can read the literature. Years ago, I had a patient with Pasteurella peritonitis because she let her cat sleep in her dialysate warmer. This is not that unusual. This study out of the infectious diseases and medical microbiology described 7 cases of Pasteurella peritonitis and analyzed the 30 others that are in the literature. And here's the thing that got me. Quote, direct contact between the pet and the equipment was commonly reported. Seriously, if you have a pet, keep them away from your equipment, be it your dialysis equipment or your central line or whatever. It's amazing how often people don't think of their cats, as a source of infections. Seriously, I've had patients who've let their dogs lick their diabetic foot ulcers, and the last thing you want is to give Fifi a taste for human meat. It's rare to be sure, but it is always good to remind patients to keep their damn vermin away from their wounds and equipment. This is depressing. If there's any disease we know how to treat, it's acute cystitis in the outpatient setting. 20 years ago, we looked at all the prescriptions for UTIs at one of my hospitals and found that nobody did it the same. There were as many ways to treat acute cystitis as there were people writing prescriptions. But things have changed, right? Wrong. This looked at the concordance with the IDSA guidelines at a, quote, university-based internal medicine clinic and found that they did it right about 1/3 of the time. Can you believe that? I guess I can, but geez Louise. It looks like it came out of University of Oklahoma. I don't understand why people publish the fact that they are incompetent. Probably would be the same thing at my hospitals, but I wouldn't publish it. But then I have this theory. And my theory is that infectious diseases is done badly by most doctors, even when they don't need to do it badly. And that as long as they have the feeling that they're giving a broad spectrum, big gun, powerful antibiotic, they don't really have to bother to learn the fine points and the subtleties of infectious diseases, not like they would, say, a myocardial infarction or heart failure. That may or may not be true, but I sometimes get the feeling that people do ID worse than any other part of medicine, even with the simple things like UTIs. Well, let's move on to a few things staphylococcal. I just thought this was funny. They looked at whether or not a mustache was associated with nasal colonization of Staph aureus. And it wasn't. But interestingly, having a mustache made you more likely to have eosinophilic clusters on your nasal cytology, suggesting that having a stash may be at risk for having allergic rhinitis. Now, we all know that patients who have MRSA have worse long-term outcomes than those who do not. Yet another study showed this particular outcome. But interestingly, there was a study that looked at the outcome of prosthetic valve endocarditis. Should you do it early or late with Staph aureus? Now, I had always thought that patients with Staph aureus prosthetic valve endocarditis needed surgery sooner rather than later, and that the mortality rates were much higher. That may not be true based on this study that looked at early versus late valve replacement in patients with Staph aureus prosthetic valve endocarditis and found no difference in mortality whether you did it early, within 60 days, or later, although there was a not statistically significant trend for worser outcomes if you did early prosthetic valve surgery in patients with Staph aureus endocarditis. I can't tell, maybe I just don't find it right, but I assume that everybody in the article had valve replacement. It was a question of early versus late surgery, and that nobody tried to cure this with medical therapy alone. But to be honest, I can't quite glean that from reading this. And they don't mention whether or not any of the patients had mustaches. And then also the problem of Staph aureus recurrences. They looked at this in people with skin and soft tissue infections and found that if their household had MRSA and fomites, they were more likely to relapse. So it's important when you have someone with MRSA, not only should they clean themselves, but their environment so that they don't get recontaminated and reinfected with their MRSA or staph in general. And let's say you want to use dalbavancin because of the intermittent dosing. So you can send a patient out who has no good home antibiotic benefits. If it is vanco susceptible, it is likely to be dalbavancin susceptible. And so you can use it as a surrogate, at least based on this study. You should also do a wallet biopsy, since these antibiotics cost about as much as a fully loaded MacBook Pro. But that's the price we pay, huh? Well, let's move on to my typical Mycobacterium. There has interestingly been an increase in BCG-related vertebral osteo in children in Taiwan, and they're not certain why. Perhaps it's just better diagnosis. The majority of children did not have an immunodeficiency, but it is interesting. As long as we're on the topic of strep bovis, there is a report out of Texas where strep bovis was found in a cat and given to several humans as well. The original source might have been either from one of the source patients who was from Mexico, or the raw cheese and visitors from South and Central America that would visit the household. But both the cat and the two humans in the household develop Mycobacterium bovis. Normally, bovis is found in wildlife, but in South Africa, it also spills over from the wildlife into livestock, so that it goes back and forth in the populations, just like Brucella does in the United States. Strep bovis does have an interesting history. It was first isolated by Calumet and Grienne, who came up with the BCG vaccine. What's interesting, and I did not know this, and shows you how patient they were, but they, quote, repeatedly subcultured the isolate on a mixture of glycerol, potato, and bile, I wonder where they got that from, for 13 years until it was sufficiently attenuated to be used as a vaccine. So they took this bovis Latin for cow, and they messed with it for 13 years before it got to the point it could be used for a vaccine. I have nowhere near that kind of patience. We always get Wiggins about new converters of tuberculosis because it's in the first 5 to 10 years that they have the greatest chance of getting tuberculosis. I usually tell people about 10%, and that's the number the CDC has. However, this study out of the Netherlands looked at the risk of developing active TB if you have exposure to a primary case. They got the same data. About 10% of people went on to develop tuberculosis. But what's interesting is that the majority of people who developed tuberculosis did so within 180 days after exposure to the index case, suggesting that that's the bigger risk, initial tuberculosis after being exposed to an index case. The actual number of latent TBs who went on to develop active TB, those who didn't take therapy, was actually a smaller number, only 2.1%. So your chance of getting active TB after being exposed to an index case is still significant, but probably your biggest risk is in the first 180 days after exposure. And two curiosities. One, a study out of New York used moxifloxacin for the treatment of latent tuberculosis and MDR-TB, and nobody developed active TB, although it was small numbers, about 30, and of course they need to be followed a lot longer. But here's a cool thing out of PLOS One, where they combined rifampin with verapamil, and verapamil increased the susceptibility of TB to rifampin, at least in the test tube, and it did so through perhaps inhibiting efflux pumps, which is kind of cool. I'm old enough to have needed to get verapamil for a patient with Prinzmetal's angina back before it was released, so I remember when that was the only calcium channel blocker. It's all in the definition. However, definitions can be important. You have to know what patient population you are treating. This study went back and recharacterized patients with invasive aspergillus using different criteria. The result of this is that it allowed more patients to be classified with their aspergillus and also with cancer to look at outcomes. And it looked like in this study with recategorization, that's like renormalization in physics, I suppose, they had better efficacy of voriconazole over amphotericin for documented invasive aspergillus. There's a table in the article that shows how they changed the definitions from the original classification to the current classification. Certainly in the pre-voriconazole days, I don't think I ever saved an invasive aspergillus. Since the voriconazole days, I don't think I've lost a patient. So I'm a believer. As long as we're on the topic of molds, just as an aside, I don't know if you read about the New York brouhaha where they looked at the contents of a bunch of supplements and found that they basically didn't have what was in them most of the time. What was on the label was not represented by in the capsule, which is often the case. This was an unfortunate case where a premature infant took some probiotics that happened to contain mucormycosis and died of fatal gastrointestinal mucor. Never trust probiotics or any of these over-the-counter supplements because they are not at all in any way standardized, and they're not overseen by the FDA. And finally, evidently, when at least it comes to molds, somebody has a urine mycotoxin test to help you for toxic mold testing. And the CDC comments, these aren't reliable. But this happens all the time, as you probably are aware. You can have a CLIA-certified lab that can offer all sorts of interesting and sometimes bogus testing. From my perspective, CLIA certification of the lab is like saying the restaurant is clean. It doesn't say anything about the quality of the product. But if you spend time in the alternative medicine world, it's amazing the number of, shall we say, unvalidated tests that are available to patients. And they often seem to be beloved by naturopaths. But ND, of course, stands for not a doctor. The ongoing depressing thing about reading the medical literature is you keep having to change your practice, or at least change your ideas. This is a study that looked at all the different effectiveness of induction therapy for HIV-associated cryptococcal meningitis. Now, I've always thought that amphotericin plus 5-FC is the way to go for cryptococcal meningitis at the beginning. However, when they looked at all the studies, 35 all told, almost 2,500 patients, they did not find that the addition of either flucytosine or azoles to amphotericin B added survival benefit when compared to amphotericin B alone. They thought maybe it was better in patients who had an altered mental status, but they could not say for sure given the numbers of patients. So after reviewing the literature, the best you can say is that there is no support in AIDS patients to giving flucytosine plus amphotericin in the initial treatment of cryptococcal meningitis. Flucytosine ain't cheap, and it is toxic, especially if you're going to be combining it with heart. So perhaps amphotericin B up front is the way to go. Not unsurprisingly, I think pasteurization is one of the great inventions of all time. Those who are proponents of raw milk are also the proponents of infectious diseases, which is good for my business. I would be disinclined to drink raw cow milk because the udder is, as far as gravity is concerned, really close to the butt. But goat's milk isn't that much better, as there were an outbreak in multiple households involving 9 people with cryptosporidium from drinking raw goat milk. Pasteurization is a good idea. And be very nervous. I have talked about the fact that people who are seropositive for toxo, among other things, have more car accidents. And this study looked at the seroprevalence of toxo in truck drivers and found that those who were seropositive had more reflex impairment and had more hearing impairment. And so perhaps worser drivers. It is scary to think, though, that truck drivers, especially those according to this study that eat horse meat, are more likely to be seropositive for toxo and, one would presume, perhaps more car accidents. My plan, should I ever get into a car accident, is to see if I'm seropositive for toxoplasma, and if so, I'm going to blame the toxoplasma rather than my lousy driving. And that brings us to the end. I really try and stick to no more than 30 minutes. The references to this podcast are available online and on the podcast itself. Don't forget to go to edgydoc.com to find links to my growing multimedia empire. If you're interested, and you should be, The Pus Whisperer, my first year's essays from Rubor, Dolor, Calor, Tumor, my ID blog, are now available for purchase as both a real paper book and as an ebook. It is perfect for the pus lover in your life. Also, in April 10th in New York City at Nexus, the Northeast Conference for Science and Skepticism, I, along with my other colleagues at Science-Based Medicine, or actually the Society for Science-Based Medicine, will be giving a day of lectures, panel discussions, and more on the topic of science-based medicine. You can find links at necss.org. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.